Hello, my name is Kalvin Pugh, and I serve as a senior advisor on community engagement for the International Association of Providers of AIDS Care. Today's special episode is all about taking back control. We're going to dive into ways person-centered HIV care and treatment can empower people living with HIV in the face of pervasive stigma that our communities face all too often in this day and age. I have the distinct pleasure of being joined today by Ramothwala, journalist and longtime HIV advocate from South Africa, Dr. Ben Young, Global Medical Director for ViiV Healthcare, and Dr. Vanessa Apea, Consultant Physician in Sexual Health and HIV Medicine from the UK. Welcome, everybody.
Thank you.
So let's start off by talking about expectations and the role this plays for our community in the context of health. Barriers such as stigma and subsequently low self-esteem persist and can affect some individuals' expectations when it comes to how they manage their chronic condition. So if all of you could share with me, why is it important to strive for high expectations, especially when it comes to your HIV treatment and conversations with healthcare providers?
I'm really happy to kick off. For me as a physician, and I think it's a great question, is because people deserve the best. They deserve the best care, and they deserve to be valued. And so when you deserve the best and you're highly valued, then you have high expectations of how people interact with you and the care that you receive. And I think all too often, that's the detrimental thing about stigma. Stigma challenges people's perception of themselves, and it supports them to lower their expectations of others. And that's what we need to challenge significantly. So for me, it's because people deserve the best care.
I can jump in to give the second doctor's opinion, and then we're going to focus back to where we really should be in sort of a more of a person-centered approach with Pholo. But I think to understand why it's important to strive, I think it's important to understand why we're striving. And that has to do with the journey and the response to AIDS and HIV. We have to recognize that we started in a time, in a place where death was the commonplace, where stigma, marginalization, criminalization was the standard. But we're now 40 years into the response to HIV, and so much has changed that we're no longer just looking to extend life by a few weeks or months, but actually the potential of decades of life and normal life expectancy has really caused us to really redefine what our expectations should be for the people we look after. And so we have to understand that those expectations have evolved over this 4-decade response to HIV. And in doing so, we really refocus this in the spirit of health equity and human rights, where everybody deserves the highest quality of care and should have the highest expectations in both medical care and treatments, as well as life. And so it's a journey. And it's a journey that's wrapped into a lot of complex history that's very intersectional with the history of medicine and therapies, but also intersectional with regard to the journey around stigma and discrimination. I'm sure things that we'll talk about in the near future.
I think for me, the important thing around this subject is that when you get the best care available, it improves whether I adhere to treatment or not. So my experience in a health facility or where I go for my care, if it's negative, then it affects whether I continue with my care. And then I think I agree with what Dr. Ben is saying around stigma and discrimination linked to care and our expectations as patients. So when I was thinking about your question, I thought, the shortest way to answer it is to say, if I get bad care, then I'm not going to adhere to my treatment. And bad care equals stigma and some form of, it doesn't even feel as far as saying, a little bit of discrimination.
I think those are all really important points to talk about, those high value of expectations after years of work in this space. And from your perspective, Pholo, of if you have a bad experience inside of a clinical setting, that is going to amplify stigma in such an important way. As a person living with HIV, I've been very fortunate having an incredible care team who led me to where I am now being, unashamed of my status and, very public about it. But that's not the case for everybody. So what is some of the practical advice you all would give Dr. Young and Dr. Apea and Fuller? What's some of the practical advice you would give people who are struggling with this?
One of the aspects of it is letting people know that they aren't alone in this. I often, when I speak to people that are living with HIV, that everyone has a different experience. Like you've just said, that you are empowered to be open unashamedly of who you are, but also you've been supported to get to that point. But there are many that haven't gotten to that point, and often when you haven't gotten to that point, you think that you're the only person that hasn't gotten to that point, and then sometimes it can be that you're frustrated that why am I at this point? Should I be more forward thinking? Should I be more empowered? So I would say one of the things is allowing people to acknowledge that they're not alone in it, and actually what the care or lack of care that they're experiencing isn't acceptable. And I think having that mindset of that it isn't acceptable can then empower people to think that if something isn't acceptable on any level, and as Dr. Young says, quite basically on a human rights level, then that then empowers people to think that this does need to change. But some of the other things is that I think one of the important things is that as a sector, we need to work really hard to show people what they should expect within a consultation, because often those conversations never happen. So someone's diagnosed, they're engaged in care, and they only know what they receive, and they may not know that there's any better out there. So I think that a really practical thing as a sector collectively is that putting out there what you should expect within a consultation and what you should expect in your care. We have guidelines and standards, but often there, as clinicians and healthcare providers, those are our standards. But I think we need to shift those into, outwardly community standards for people to be aware of the care that they should be receiving. So that's just one aspect.
I couldn't agree more with you, Vanessa, that this is multi-sectorial. But establishing the ground rules and the ground expectations, if you will, that everybody deserves to be treated with respect is a really important level setting. And it's one that doesn't always happen. And there are many forces behind that, right? So there are many forces from the medical institutional perspective, from the healthcare provider perspective, and of course, from the perspective of the person, the patient. And sometimes these can collide in a way that's very non-productive and stigmatizing. And it's a challenge, and it's one that I think requires constant introspection to elevate. We're all very busy in the clinic, and sometimes some things get in the way of the most productive and respectful conversations. We have to appreciate that stigma occurs in health settings. It's a very frequent thing that patients have told us. We have to be mindful that people bring their own baggage to the conversation, and people living with HIV may have their own challenges and demons with self-stigma, whether it's related to HIV or other aspects, intersectional aspects of their life. And so it means that we need to, continue to work to provide that respectful and non-stigmatizing, non-judgmental environment. But it takes effort. It's not very hard, but it does take the effort to do.
Yeah, I think for me, as from my own experiences, I also run these forums for people living with HIV, and we actually had one a couple of days ago where a few people were saying to me, "Look, the reason I'm treatment fatigued, I'm tired of taking my treatment, and my doctor does not understand." And so my question was that, okay, what kind of a conversation are you having with your doctor? And I think just like Kevin, I'm lucky because I've got a private health care. I can look after myself. I can access whatever care that I need. I'm open enough to engage my doctor. And when I disagree with my doctor, we disagree, and we come to some kind of an agreement. But a lot of community that I work with, it's not people who can challenge, if I can use that word, their care provider to say, look, I'm saying that this is how I feel about my medication. Let me give you an example with side effects, for example. The standard line that a lot of care providers will say is that, no, just hang in there, just keep taking it, you'll be fine, without any explanation of what that means when somebody says you'll be fine. And it's important that that conversation between a care provider and a patient, I call it equal. It's an equal relationship. You can't have a conversation where you just get instructions about this is what you must do, and then that's it. A patient should be able to ask questions that helps them to stay on treatment and then improve their care. That's how I see it. And then, it's an everyday thing for me with the people that I work with.
So stigma can really affect the mental health and emotional well-being of people living with HIV. I think we know that's true. We just discussed it. There can be a significant effect on how people feel about themselves, their treatment, and their care. Despite high overall satisfaction with current antiretrovirals and the advent of brilliant campaigns such as U=U, some people living with HIV still face a range of challenges with daily HIV therapy. Can you tell me a bit about why and how we can encourage people as they age with HIV over their lifetime to overcome these challenges to support their mental and physical health?
Again, I think the first thing is to recognize that the potential for people to live normal life expectancies, to therefore pivot our thinking around something past just one viral load that's suppressed. We're looking down the road for the potential of normal life and wellness. Now that's aspirational for many people, but in fact for health workers as well as for patients, sometimes that almost seems inconceivable, depending on where they start in this journey. But we have to recognize that that taking a medicine is a reminder of the disease. It's a reminder, therefore, potentially of the stigma and discrimination and criminalization that may impact the disease, the virus, or the person. So it means that we have to have a conversation that is long-ranging or thinking about the future that includes getting older, growing old, the future, therefore, that embraces other potential medical comorbidities, other changes in housing and food security and relationships with people. But all of that is predicated on having good medicines, and medicines that minimize both the impact of disease, the impact of the medicine itself, and the impact, hopefully, of the stigma that's associated with that entire ecology. We're fortunate to have many of those options today, but it requires an empowered and non-judgmental environment to have that conversation.
I couldn't agree more. And one of the things I really wanted to pick up on is something that you said earlier, Ben, about, it takes effort. It's not hard, but it takes effort, because what you have to recognize is that across one's life course, life is dynamic. So you can be in one space and be in one point in your life where taking pills is fine. You're on it. You're in the morning, you're taking it when you go out and do everything, and you've integrated it into your life. But then 5 years later, social circumstances have changed, relationships have changed, your body's changed, and how you feel about life has changed. And what needs to happen is that the sector around needs to be dynamic as well, and it needs to give you an opportunity to say life is different, and to ask intentionally, how is life at this point? What do you need? Do you feel differently? And I think that having that regular introspection of ourselves as healthcare providers and the care that we're providing, and also allowing people living with HIV that we're working with to ask those questions of themselves is just so crucial. And I think it's that concept of related of, when we're designing services and care, we talk about, cultural competence, thinking about that person and as an individual and what's going on in their cultural context. But actually, it's really that concept of cultural humility, to be constantly thinking about that person as having many intersectional identities, which evolve and impact them in different ways over time, and to ask and then to shape services and care around that. And I think that's crucially important because, as has been said, the expectation of living with HIV has changed, and also bodies, emotions, life changes, and we've got to find ways to support that change along the way.
I think it's really powerful there, Vanessa, because I think about where I was 6 years ago when I was first diagnosed to where I am today. Those are two completely different individuals. What's priority to me today was not priority 6 years ago. How about you, Pholo? How would you encourage people to, as they age, to over their lifetime, to overcome these challenges?
So let me give you an example with myself. So I'm 43 years old, and I've been living with HIV for 23 years. 13 years of that I've been on treatment, on antiretroviral treatment. And 2 years ago, I started taking hypertension medication. And a couple of weeks ago, my doctor said, you need to take cholesterol medication. And I can tell you now, I look at this medication, this tablets that I need to take, and I'm like, do I really need to be taking all this? And that's more psychological than anything else. I know I need to take them. I know I need to look after myself, but it's hard. It's hard to, every time you almost, when you go to a doctor, you think, I don't need any more bad news, And once you start thinking like that, it feels like it complicates things. So hence you needed a care provider that will be able to interact with you and understand the dynamics that you are dealing with, so that, at least by the time you leave your care provider's rooms, you've got some level of assurance that, I'm doing the right thing. So in my world, I don't see care providers as just medical doctors, but you also play a bit of psychology in the services that you provide. So that's how I see it.
I think that's a really important perspective. A lot of folks start with one pill once a day, and then we're going to get older and take more pills. I had a really great conversation with a friend of mine who has been living with HIV since the 80s, and the amount of pills. But if it weren't for all the work that was done before I was diagnosed, it wouldn't be as simple as it is for a lot of people today. So it's my belief, along with, I'm sure, everyone here today in this conversation, that everyone should be treated with dignity and respect. We can't really touch on stigma without talking about key populations. Members of key populations are still being left behind in societies and healthcare around the world. Here, where Dr. Ben and I are in North America, where you are, Pholo, in South Africa, and Vanessa in the UK. How can we do more to show up for members of key populations when it comes to eliminating stigma as a barrier to care and treatment?
I'll start off. One of the key things is I think we need to keep showing up. I think that and continuing to advocate. And outside of our sector as well, it always shocks me when you, because sometimes we're in a bubble within our sector, and we'll talk to people, like-minded people, and you feel refreshed and inspired, and you think, we've done a lot, we've got a lot more to do, but we're doing it together. And there's a certain momentum and a community spirit. But the issue is that when you step out of the sector, that level of education, support, advocacy isn't there. And so I think it is absolutely crucial that we step out of the sector and keep on raising awareness about different people existing, number one, and then their needs, because I think I'm always surprised by some people that don't recognize that there are different people with different lived experiences just down their road. And the impact of their behavior and society's behavior on those other people. And so I think that's a really important part of showing up outside of our spaces as well.
Yeah.
I think you raised some really important points, Vanessa, that it is about showing up. It is about recognizing differences. I think you used the term I embrace fully, or you introduced two terms, one which was cultural competency, but the other was cultural humility. Competency means that you know everything about something. Humility says that you actually acknowledge that you don't know everything about everything. And I think it's the latter that is first the important thing, is to recognize that people have differences, different journeys, different cultures, if you will. And so it's important to have a bit of an introspection, both at the personal level as well as the institutional level. And in doing so, then I think, can make steps in creating more welcoming places for people of all of that lovely diversity. But I think there's one additional step, especially when it comes to marginalized populations of people, or even beyond that, regardless, just individuals who may feel marginalized, regardless of what they look like or how they present. And that means creating, especially in the health setting, which is supposed to be a safe harbor for people, that we have to recognize that there are many both spoken and unspoken things that create unwelcoming environments or less humble environments. And ultimately, it's the idea of being allies for people, allies for health equity, if you will. Again, that's a never-ending task, but one that is a challenge that has been my career's DNA, and one that I hope that patients ultimately benefit from, because it's not about the doctor in this case. It's actually about improving the lives of the people we look after.
Yeah. I think for me, Calvin, I say it's the clever ones that you get to a point you realize that they actually don't know much. It's surprising that in some cycles, I think you go and you expect your doctor to be understanding that they are dealing with a sex worker. And instead of, having a conversation with a sex worker as a patient and a human being, the judgment of dealing with a sex worker comes first. This morning we just had a long conversation about people who inject drugs in my line of work. And when we're getting the reports, we're told that about 21% of the what we call human rights violations that people are experiencing are through in healthcare settings. In an environment where people are going there to seek help. So the important thing that I believe healthcare providers need to look at, yes, you are a medical doctor, you are a nurse, a whatever qualification you have, but you're dealing with a human being. That's a right for everyone. And if we are not practicing, the right to dignity, then we have a problem. Everyone has got the right to dignity. Whether I'm living with HIV, I'm using drugs, I'm a sex worker, I'm an MSM, my right to dignity is equal to whoever is around this world. So that's the advocacy that I think we still need. So we need to expand the advocacy. We need to expand the engagements that, in a healthcare setting that are being held with those that are not within the circle. Because you've got those who know, because we participate in all those platforms. And then there are those that are outside the platforms. And those are the ones that we need to reach out to more.
I'd like to kind of share with you at least one, you could say a research anecdote, but I think it's an important observation that came from a study that I helped with called the Positive Perspective Study. And Positive Perspective was actually a community, a patient-driven, steered investigation of the lives and experiences of people living with HIV, about their experiences in the health setting, their experiences in health, and their experiences with medicines. But I think one of the most striking things about this survey of 2,400 people in 25 countries around the world was that what people think are their most important concerns, very frequently were also the things that they felt uncomfortable talking to their doctors or their healthcare workers about. And these were individuals who had navigated the HIV care continuum, were in care, and were receiving therapy, and yet a full third of people had difficulty, felt uncomfortable talking to their doctors about the very most important things in their health, in the tableau of their health concerns. And so I think it means that we have to think very carefully, very humbly about the nature of the conversations that happen in that very private, hopefully confidential confines of the health worker-patient relationship in the clinic. Because ultimately, if we are able to enable and empower that kind of productive, respectful conversation, will ultimately direct us in a way that will have more productive and caring relationships and ultimately better wellness and health for the individuals we look after.
Yeah, yeah.
I think all of you made a really solid kind of indication of, stigma is kind of this like pool of all these intersecting identities, these things that are already maybe treated as taboo, or as one of my favorite people says, it is the Trojan horse of oppression. Things like race, housing instability, substance use, sex work, all those things that are stigmatized in our culture, and they kind of convene in one space of HIV. It kind of comes to this like head where folks are stigmatized for lots of things, and those are conversations that should be had inside of a provider room. Those are the kind of, you want to build that kind of trust with your the clients you serve, or the clients want to have that kind of conversation with their doctor, that they feel that there's that two-way relationship, and that there's no place in that space in a healthcare setting that is unsafe for them to be themselves, and to be open with their providers.
You put it so well. Yeah, completely agree. And I think recognizing that consultations and being in that healthcare space is a two-way thing. So you have to bring yourself, and the other person has to bring themselves as well. And it's that thing of, as a healthcare provider, I think about this a lot, about remembering that some people need you to legitimize them to talk about sex, to talk about relationships, to talk about fatigue with pills, to talk about fatigue with life, or fear of going grey, creating spaces where people feel that they are allowed to talk about those issues. And often, as Vanessa said, which are, a fascinating study, is that people don't feel that they can. And so it's our responsibility. We tell people to write a list of everything that you'd like to say in your consultations. And that's really definitely true. But then also on the other side, providers need to also, I think, also have their list of saying, let's touch on this, let's touch on that, to make sure that people feel that anything they want to talk about is, no holds barred. It's all free in this space together.
I think that's putting it beautifully, Vanessa. Well, I was going to start with you. So you can give me an example of a time that you felt stigmatized in a healthcare setting, didn't feel like you could speak freely or openly, or face pushback from your healthcare provider?
Kalvin, I come from the activism background. So there is no doctor who will not allow me to speak if I want to speak. So I have walked out of a consulting rooms because I just felt that I'm not being treated right. So I clearly said to the doctor, I am not happy with the way that you're treating me. And I left. And that was during COVID. So you could tell that the doctor was very uncomfortable in treating me. So I said, okay, let's end it here. But, there are people that they've had bad experiences, where, a care provider comes in as kind of a superior level. I know everything, you don't know anything. This is how I'm going to tell you, this is how it's going to work. And that's a problem. That's a problem in many to many people who just need 5 minutes with a care provider, where a care provider can listen to why I'm saying I'm feeling nauseous every 10 minutes. And that level of listening, it doesn't need an hour, just enough time to listen to a patient and allow the patient to be free enough to be able to express themselves is important. So many of us, I think, I can stand for myself, but there are many people who can't stand for themselves. And those are the people that needs to be protected in the consulting rooms by the healthcare provider, by the way. The care provider needs to protect the patient, not violate them.
Dr. Young or Dr. Apea, do you have any thoughts on times that either you personally felt stigmatized in a healthcare setting, or you witnessed it in your workplace?
Well, I mean, I may be the old man in the room here, or the old person in the room. I mean, some of this is the baggage that I mentioned earlier about the journey of HIV. I mean, I remember the earliest days of the epidemic in Manhattan, in New York City, one of the ground zeros, right? And where health workers wouldn't enter the room of people who were diagnosed with AIDS. And I remember the sound of food trays crashing into rooms as food workers tossed food trays into patients' rooms. Um, but that was a long time ago. I think we see stigma all the time, or at least we experience stigma all the time, but we don't actually sometimes fail to recognize it or fail to stand up to it. And I mean, I say this as an Asian American, and only frankly recently recognized the frank systemic bigotry that I have faced most of my life. And so it is something that we live in this kind of bouillabaisse of opinions and systemic issues that lead to inequities in lives. And so I think it's both. It requires an awareness that this happens, and the ability, you could say the empowerment to say something about it in the context of the health environment. Those of us with stethoscopes or diplomas actually come to the conversation in an unequal power relationship, and I think we need to appreciate that, because with that additional you could say power in that relationship, there's a responsibility to level the dialogue and to appreciate that power relationship can actually either be the perpetrator of making stigma worse, or can actually be the tool to actually fix or at least to alleviate stigma as appreciated by the patient or the people that we look after. It's a challenge, and I'd say I challenge all of us, not just in the health setting, but in all of our relationships, to recognize and do something to make the world a bit more just, and in doing so, then decreasing stigma discrimination as it affects people living with HIV and perhaps other themes in our society.
Again, we're all in line with our views and reflections. Taking a step back on a personal level, I'm a Black woman. I've experienced a lot of racism, gendered racism, whatever you want to call it, experience that. And I've experienced it in healthcare as a medic. And that's the thing as well. As soon as you are in that setting as a patient requiring care, it is all about power. So it shifts completely, and the vulnerability comes right out. And I have been shocked about how vulnerable I felt and how it's taken a lot of me to empower myself and address any stigma and discrimination that I've faced. And I've also, again, seen it time and time again for the people that I look after. And it is about recognizing it and calling it out. But sometimes it's finding the right time and way to call it out as well, that it doesn't become more detrimental in that specific time. But I echo the viewpoint of power, because the doctor-patient relationship, that power there is the crux of everything. Because as a clinician, what does happen is that you can determine what you listen to and what you hear and what you ask, and then and that determination and that power can be enabling to someone, or it can be disabling, and it can silence them, or it can actually empower them to speak up. And so I think, again, we come back to that ongoing search for humility in providers, to constantly feel, am I sharing power in this dynamic? And am I sharing power in this conversation? And I think that is ultimately crucial.
So I think what we've said is really important, empowering people and that power dynamic inside of a clinical setting. Do you think there's anything else you could add to maybe equip people who might be in in a situation to empower them to talk about what they need on an individual level, including a proactive treatment plan?
I mean, one of the things I always say is at the end of an appointment, right? I'm going to be seeing you in 3-6 months, or you may be contacting me in between. Have a bit of a diary, tell me, because one of the things I ask is, of the last week, how many days were good and how many days were bad, and what makes up a good day? Because what I think is good could be very different to what you think is good. Because it's really difficult when you're asked right now, how did you feel yesterday? What did you even do yesterday? You're scrambling to think about it. Whereas if you've encouraging people that to write it down, but also they'll be allowed to voice it, I think is really important. So having that aspect of reflection, and actually in those bad days, what would have made it better? What could your clinician do to help? I think having that reflection before the appointment and writing it down can be really powerful. And the other thing I always say to people is bring someone with you. Whether it's in your circle or peer support from an organization, but having it written down and being prepared with someone with you as well, I think is really crucial in empowerment.
I can build on this. Vanessa, you've reminded me of a few things in a sort of a synonym kind of way, because what you described has been described at the sort of policy and community level as really as quality of life for people with HIV. And of course, I think this has now been embraced by the UN with the so-called Fourth 90. It's been embraced in a number of initiatives around elevating the importance and the awareness of quality of life, both for patients first and foremost, but also in the context of how we conduct ourselves in the doctor-patient relationship, in the health institution-patient relationship. And I think one of the things that to me is really foundational in that awareness is actually asking, so I don't define my patient's quality of life. I don't have any preconception of what your quality of life, Vanessa, how you may define it, or how Pholo may define quality of life. It actually requires asking people what their quality of life, how they define quality of life. That might be, how do you call what are the measures of a good day or a bad day? And ultimately that, again, level sets the relationship in that power balance, because it actually allows the patient to define what the endpoints should be, whether they're good endpoints or bad endpoints. And that directs the conversation in a way that allows the health worker to focus on what's important for the patient. Now, granted, it's a matrix of things that we have to talk about in a very brief amount of time. It's linking ultimately all of the fruits of the science and medicine into what does it actually all mean? And the way we probe that, if you will, is having communication with the people we look after. And so I actually want to kind of just let me do a little bit of I don't know if it's a definitional kind of piece, which is to say that, ultimately high quality person-centered care actually is synonymous with high quality communication, non-stigmatizing, non-judgmental, and oriented towards the person we're looking after. I spoke about the positive perspective study earlier. One of the things we did was to try to ask the people who participated in the study, what was their experience in the health setting? What was the communication like? Did the healthcare worker ask them about the things that they were worried about? Did they ask them about aging? Did they ask them about, take the time to tell them about the new medicines that you spoke about, Vanessa? And one of the things that we found most striking was that there was a really strong relationship between the quality of the communication with, first off, things that we think as doctors, in the most kind of crude sense, we care about viral suppression. It turned out that the quality of the conversation actually predicted patient-reported viral suppression. It predicted patient-reported adherence to medicines, things that I think we could all agree on are very orthodox things that are important to even non-caring doctors. But the thing that was even more striking to me in this was, again, around the world, regardless of the country and race and medicines that people were taking, was that the quality of the conversation between the healthcare worker and the patient also predicted very strongly, statistically significantly, the patient report of their wellness, of their overall wellness, their physical and mental and sexual wellness. And so there's something magical that happens in the conversation, in the private conversation that we as doctors have with our patients, that actually enables all the other things that happen in that tableau that ultimately, in my opinion, reflect the things that are most important, which is the patient's report of wellness.
Yeah.
And that's magic. And so I think it really elevates the importance of that conversation.
Yeah, I agree with you. For me, the way that a doctor talks to me determines whether I go back or not. It's as simple as that. If the service and the communication it's what I refer as bad, I will not go back. So I'm lucky I've got the same care a doctor for the past 10 years, but I also travel a lot. So sometimes I happen to be in a different area. You meet a different doctor, and then I'll never go back if the experience is bad. And because I actually participated in the positive perspectives. So some of my South African colleagues in the forums that we engaged around this, the relationship with the doctor is one of the most important issues that keeps coming up. That we have a general practitioners who most of them do not understand a lot about HIV management, and you go there, you're talking about side effects, and then the only message you're getting is that now stay on this medication because there's nothing else.
I think that's really important. And I kind of want to circle back to kind of everything that we've talked about today, in kind of the lens of people aging with HIV, the specific challenges they're facing with things like polypharmacy, and what we've talked a lot about today, which is quality of life beyond viral suppression. So do you consider choice to be one of the most promising and powerful ways to reduce stigma, both in and outside the healthcare setting?
I think choice is pivotal, but it needs to be matched with an infrastructure to explore what that person needs at that time. But I think choice is pivotal. And I think watching the transformation in people's lives with that choice is something that is a privilege that we have as healthcare providers, because everyone has their unique experience, and we can offer the perspective of, right now you may not see how it could fit in, but I can offer you experience of others that I've looked after and worked with. Other peer support colleagues may be able to give you that perspective as well. So it is a privilege that we have to be able to provide that added layer of perspective. But I think choice is crucial. Yes.
No, I completely agree, Vanessa. But choices are sort of a funny broad term, right? Because there are limited choices in medicines, because there's only a limited number of medicines. But choice is in my view, it's also like it's being informed. It's being informed about what the available choices or options are, rather than let's say for me to just tell patients this is what you have, and this is the disease you have, and this is the medicine that you're going to get. I think it's and the wonderful richness of this and successes of the discovery for new medicines for HIV actually does give us some latitude in those options, very good choices. And that's where we can overlay those choices with the individualized, person-centered conversation that is respectful and so on, ultimately reflecting that intersection of this marvelous thing we call doctor-patient-virus relationship, and trying to sort out what is the best medicines, the best approaches for an individual, with an individual array of health concerns, an individual array of health conditions. And ultimately, that's where we find the best fit for the person. It's not just the sort of the one-dimensional or two-dimensional view of this is the virus and this is what I treat it with. It's actually adding in all of those other things. And ultimately, that is about best fitting those choices, those options for that individual. But I think the important piece that has been missing was elevating the value of the voice and experience of the person into that matrix to empower a better fit among those choices that we have.
If I may just pick up on that, Ben, you're so right. And one of the things as well is adding into that matrix, as people age, more and more clinicians get involved, and they don't often understand that matrix and don't see where they fit into that. So that's another layer of what needs to be supported in that engagement as well.
Absolutely. The aging is like this, again, it was this unexpected fruit of the science, right? Is that people do live longer, live very long lives, potentially and hopefully. And that adds this previously unexpected complication or factor in that matrix, right? Again, we keep talking about positive perspectives, but it is that person-centered perspective that we are talking about. And one of the things that I found most striking was that in the positive perspective study, globally, regardless of country, people were concerned about what happens as they age. They were concerned about taking more medicines, even in a sense more so than perhaps the HIV doctors in the, it's like, well, here's your medicine and, and your viral load suppressed and off you go. The people that participated in positive perspectives like Pholo actually told us categorically that they were worried about these things. They were concerned about these things. And yet I think about the many thousands, tens of thousands of doctor-patient encounters that I've had. I can't say that I actually asked people, are you concerned about taking, are you concerned about polypharmacy? Are you concerned about the side effects, the changing of side effects as you age? But yet actually people were both aware of that and were concerned about it in positive perspectives all over the world. It was really striking.
I'm still worried even today around, aging. I gave an example with some of the medication that I'm taking at the moment that it's too much. And I do not remember ever having a conversation with a doctor about this. I think, in fact, I got exposed to aging when I was part of Positive Perspectives, and I started thinking about it. And I asked some of my friends that, do you ever think about this? And like, oh yeah, actually, it's relevant to where I am, because you're talking about people who have been living with HIV 20, 25 years, and there are things that are changing with them, and we do need to invest more time in having conversations about aging with HIV.
I want to thank my guests today, Pholo, Dr. Vanessa Apea, and Dr. Ben Young, for joining me today for this important and timely conversation. With all the challenges we face, it's never been more important to talk about power dynamics with our providers, the power of choice, the importance of things like polypharmacy and quality of life beyond viral suppression. It's now more important than ever before to take back control of our health, to find joy, to make way for our most empowered selves. And it's also important that we end HIV-related stigma. For this reason, IAPAC has partnered with other global organizations to launch a new awareness day, Zero HIV Stigma Day. To find out more, go to www.iapac.org or www.zerohivstigmaday.org. For additional resources, see the show notes. Thank you for joining us today. Please be kind and take care of yourselves and each other.